مساء الخير جميعا. Thank you, Professor Magda, for the kind introduction. It's a pleasure for me again to speak today for the second time in Bahia Conference. It's always a pleasure and an honor to participate with such a prestigious establishment and conference. Actually, my talk today is about breast cancer in pregnancy and lactation. That's the title that is written in the program, but I certainly added a third part, which is the postpartum, because it's all one and the same process. It's a bit of a gloomy subject, but we have to deal with it anyway, and we will know why. So the outline of my talk will be, first we have to start with the definition, and then the incidence, how many cases are we dealing with, clinical picture, and the oral biopsy, which is elementary, and then go through the immunophenotyping of these tumors as well as the process of involution. We'll talk about involution, what it is and what it does, risk factors, and lastly, future trends. So let's start with what is the definition of pregnancy-associated breast cancer. Actually, it is cancer diagnosed during gestational period, of course, but equally important, postpartum era, including the lactational phase and post-lactational phase, which can extend from 5 up to 10 years in the lifespan of the patient. So it is not just gestation, it's not just pregnancy, it is a long process, and we'll deal with what happens during this very long history and travel. This is the window of opening of the breast cancer-associated cancer. It starts around the age of 19 and goes until the late 30s and even extends up to 40s. The incidence. Still, breast cancer is the most frequent tumor during this period of pregnancy, whether it is related or unrelated. The incidence, it was used to be 1 per 3,000 pregnancies. However, due to the delayed pregnancy cascade and lifestyle of the females now, unfortunately, they've postponed the process of birth and childbearing period from the 20s or even teens down to 30s and now even 40s. So the delay increases the risk more, so that the incidence now is about 3 per 3,000 pregnancies. Yes, it shows that it could be low, but in fact it's very dismal when it occurs, and we've been seeing a lot of cases lately. This is the gloomy, dismal part. But the good part, there is a good part, which is this does not affect the baby's development. For those who are or wanting to make a decision about their baby or their life risk, then they should know that it has nothing to do with the baby. The baby will be delivered normally and will have no hazardous effect on the body. And it's not passed to the child during gestation, the genetic malformation, which caused the disease, is not transformed to the baby. And this baby, when even she grows or he grows up, they will never be related to this disease at all. So this is the good part of it. And this helps very much the female to understand so that she can make a proper family decision. It's not her decision, it is the whole family issue. What's the clinical picture? Usually this is what happens in contrast to other lesions, that the breast mass is being discovered by the patient herself. Why? Because she is undergoing a measurable change in her breast. The breast is enlarged, it is engorged, it might be a little bit painful, tender, some discharge from the nipple, maybe blood or otherwise, and some skin changes. All that occurs, and it's alarming for the patient. So whenever things like that happen, the patient will seek medical advice because she felt the mass or observed the change. So biopsy is the gold standard for diagnosis. There's no way around it because of so many factors, and probably the biopsy is informative and correct in most of the cases. There may be some changes or complications for the biopsy, which are really trivial, like a milk fistula or infection or whatever, and this can be dealt with prophylactically. So if you look, how many pathologists in the room? Good. So if you look at these two biopsies, the one on the left, yes, is the normal lobule. We see how quiet it is, how small it is, and very, very innocent. But look at the change on the right, and this is still normal, physiological, lactational changes in the breast. And in contrast to a tumor, the tumor is a localized area, but with lactation, this is a huge change because it deals with the whole breast tissue. So there is massive increase in breast size, and of course, the texture again is different. So you see how much difference there is. It is a rather a very huge change physiologically in the female's body. And again, not only the breast lactational hyperplasia or proliferation, tumors could occur. A lactating adenoma could be there. And not only that, a normal fibroadenoma that has been going on before pregnancy could change into a lactational activity and becomes a lactational adenose. So you see a lump in the breast, maybe 80% or 85% of which will not be alarming, will be either hyperplasia or benign tumors or infection or whatever. But in this 10 to 15% of them, unfortunately, cancer could set in. Some adenomas may undergo even cystic degeneration, and this even can cause more enlargement of the breast tissue as a whole. Unfortunately, malignancy can set in. And here are the glands that are lined by malignant cells, but again, they are intermingled with the residual of the secretory lobules in between. The disease is usually either of aggressive nature, as we talked this morning about the young age breast cancer, HER2 positive tumors, or triple negative tumors, and both of them are quite aggressive by nature. So the profile of pregnancy-associated breast cancer usually, of course, comes to the young age, up to the age of 40, ductal carcinoma, high grade, large tumor size, advanced stage, higher nodes metastasis, and rapid course, and all the bad criteria of HER2 and KI proliferation. If we compare the data of the pregnant breast cancer versus the non, we'll see that the stage is a bit higher in stage 2, 60 versus 56, 74 versus 62. The negativity for hormones and HER2 positive is 48, in contrast to 34 in non-pregnant breast cancer. Triple negative, look at the numbers, 39 versus 26. So they are more inclined to be HER2 positive or triple negative. Again, the postpartum status is an independent factor for pathologic complete response. This is again another good story about this whole thing. And it is well known that the postpartum breast cancer status is more sensitive to chemotherapy than others. Now let's move on to the pathophysiology. What happens? The breast undergoes massive change during the lifespan of the female, like no other organ in the body. Starts, of course, the childhood and then puberty, where some of the collagen inflammatory reaction, immune reaction occurs. Then if she gets into pregnancy, a lot of collagen and protease enzymes, monocytes, lymphocytes, and all that will be increased. It will again be suppressed, subhanAllah, by lactational activity, because now the breast does not need stroma. And then after the cessation of lactation, what happens, what we know as postpartum involution. Now, otherwise, if the female does not pass through this process and she is nulliparous, then from puberty directly to the perimenopausal age-related innovation again, changes again. So I've mentioned the word innovation twice, and let's see what innovation means. It means there is marked remodeling program in the postpartum period, and it extends up to 5 to 10 years postpartum. And of course, there will be cumulative effect if there are repeated pregnancies. What is innovation? It is a process that has been simulated to the process of wound healing. It is an inflammatory immunoprofile with marked increase in lymphatics, extracellular matrix remodeling, and the loss of epithelial component which was used during lactation. Now the breast doesn't need us, and all that is being activated by what is known as COX-2 upregulation. The effect here, I need you to understand this, the effect is that if this innovation process occurs during which mutational changes are affecting the stem cell and the immature progenitor cells that we talked about this morning, then and only then this innovation process will cause a lot of adverse effects like seedling metastasis and bad prognosis in general. And here is a diagram just to describe that. That's one is the normal duct, and the other one is a duct clogged with the innovative cells. Together with some of them on the surface will be having what is known as COX-2 receptor, and this induces a lot, really a lot of stromal collagen reactivity and inflammatory reaction. Thus, the scientists began to think, well, if this is an immunologic inflammatory reaction induced by the COX-2 upregulation, then why not use anti-inflammatory, non-steroidal anti-inflammatory drugs? This has been tried on experimental level with some degree of success, but not really yet clinically. The pathophysiology here is a bit contradicting because pregnancy has a dual effect on tumorigenesis. It has a protective effect against cancer in general. We always say that those who are active with childbearing and lactation, they are spared or mostly spared the hazardous effect of cancer. However, when innovation occurs, then it has a hazardous effect because of the very say florid lymphatic permeation, a lot of stromal cell reactivity, and so on. So don't get me wrong, innovative process does not induce cancer. It's just there as a risk factor if the mutation occurs during this period on the stem cell and the progenitor cells that are very, very rich in this area. And this diagram I'm trying to elucidate because it took me some time to understand it. If we look at the breast cancer risk over time, then pregnancy and childhood bearing will have an effect, a strong effect on the protective effect of this process on risk, on breast cancer risk. It decreases it. However, there is a small transient risk of breast cancer occurring at the young age group. When mutation occurs then in this young age group, then pregnancy and lactation will have an increased risk for breast cancer. I hope this is understood. However, lactation is a much more easy to understand relation, straightforward. Prolonged lactation will decrease the risk for cancer, while no lactation will increase the risk for cancer. Involution, as we talked about, has only one way to go. If mutation occurs, then involution will really have as a hazardous effect on the tumor behavior. And I showed you this slide this morning. Yes, mammary tissue in young females is very much enriched with immature mammary cells, that is the stem cell and the progenitor cells that are very, very rapidly proliferating. That's the mother cell, like mother, like daughter. If the mother cell is a stem cell, then it will proliferate quite frequently, and this will increase the significance of the degree of malignancy, and these cells, they do increase tremendously during pregnancy, menstrual cycles, and lactation. So the fact is, when these occur, then they carry on the bad prognostic profile of such tumors. The etiology of pregnancy-associated breast cancer is it has no relation to family history. It has no relation to BRCA1, for example. It is due to the occurrence of mutation at an early stage, aggravated by the process of proliferation, lactation, and so on. And then it is very rich in stem cells and progenitor cells, which are very much flared during pregnancy, and they have a hazardous effect in case of proliferation and malignant profile. Hormonal changes can also cause a transient phase of immunosuppression. Involution, as we talked about, which is the retrograde development, will cause some kind of a pro-inflammatory microenvironment and favors the growth of dormant tumor cells. And that's how they began to think of non-steroidal anti-inflammatory drugs as a test. Termination of lactation, على طول, the moment lactation is stopped, the breast comes back to no epithelial lobules full of milk, and there is this remodeling and development of some transformed cell. So the future vision then, definitely this disease is of totally different genomic signature, with a lot of increased expression of immune response mediators, aberrant expression of so many oncogenes and tumor suppressor genes that affects apoptosis, DNA, repair, proliferation, and so on. The immune response in itself could be a target if there is high increase in HER2 and Wilms tumor, and these genes are very much indulged in embryogenesis and organ development, so these could be used as targets to shut down this mechanism. The future trend then, we know now that trends going towards non-traditional pathology, للأسف, but maybe the use of some molecular tests to really get the feel of the disease in its very, very early phases. MicroRNAs are known to increase tremendously in late postpartum period. Of course, it can decline from the year to the second year, but it will still be there. And these microRNAs will be carrying an epigenetic modulation that is the print of the tumor in them as they circulate in the blood. And this is, will go on in all phases of pregnancy and even puerperium and maybe postpartum for a while. So in fact, liquid biopsy may be there for the early detection of such very, very hazardous disease. And we really hope that they come with the solutions soon, because it's a very tragic situation with the mother having to deal with the cancer, with delivery, with abortion, with continuous, and take a decision based on the right management of the case. These are some of the references that I used to prepare this talk for you, and I thank you.
First of all, I would like to thank the organizing committee for inviting us today, especially for all this effort performed by Professor Amani Hilal, Professor Rasha Kamal, and Professor Maher Hassan. It's a great pleasure and honor also to present my dear colleague, Professor Hanan Izzat. She is a professor of medical oncology at the National Cancer Institute and the head of the department at the Armed Forces College of Medicine. She will talk to us today about drivers of adjuvant chemotherapy in young breast cancer patients.
صباح الخير. طبعا يعني it's my first time to be in Bahia conference and الحقيقة I'm very proud. And also very proud to be talking after my esteemed dear Professor Dr. Nadia Mukhtar طبعا. I would like also to thank Professor Dr. Amani Hilal for her kind invitation. الحقيقة إنه ال topic of discussion today is a very hot topic with a lot of controversies. وأنا الحقيقة انبسطت جدا لما دكتور أماني طلبت مني أتكلم في الموضوع ده. It has a lot of things to be clarified الحقيقة أو highlighted. So today I'm going to يعني press on the point of precision medicine in breast cancer, in early breast cancer. So we are going to talk at our aims at the coming time, how to increase the patient's survival with a decreased use of chemotherapy. This is the main key of the topic today. So how can we give the patient her best chance with decreasing the use of chemotherapy? So first of all, I would like to highlight that precision medicine is something very old. It goes back to the 18th century, where first time Professor Albert thought about doing ovariectomy for a patient with breast cancer in order to decrease the hormones. Actually, he got this idea, but who started to do it first was Sir George Pitson. He was the first one to go for an ovariectomy for a patient with ovarian cancer, and of course, the results were great. After that, in the 1950s, came the discovery of the hormone receptors, and after it, a cascade of hormonal treatments have been invested. Then in the 1980s came the discovery of the HER2, with all the anti-HER2s that are coming to us every day, and finally, the molecular subtypes. So precision medicine is a very, very, very old idea. So in order to start our discussion, I just want to highlight the ESMO guidelines. Of course, they were updated in the year 2023. And if we look here, we'll find that we have few biomarkers to be done for any patient with breast cancer. As we all know, we should be having an ER, PR, HER2, Ki67. Recently, we used to ask for BRCA testing and also gene expression assay. I put this slide only just to highlight that. So where is the pointer? That now, when we are talking about breast cancer, we are not only talking about the stage of cancer, we are not talking about the molecular types of cancer breast, but also we are talking about the early response to chemotherapy or to new adjuvant treatments. So what's new that has been added in the past decade is the effect of the early treatment on the patient's outcome. So let us have a look at all these graphs. You will find these graphs is discussing the pathological response and its effect on the patient's survival and disease-free survival. So if you look here, we'll find the patients with luminal B. Patients with luminal B, as you can see, patients with HER2 positive and patients with triple negative, those patients who have developed pathological CR, usually they are getting the best disease-free survival. So what we are going to highlight today is that the effect of pathological complete response is very important on the outcome of the patients, especially patients who are HER2 positive and triple negative patients. So this is the ESMO guidelines for the hormone receptor positive, and as you can see here that they split the patients to patients with tumors less than 2 centimeters, who can go for upfront surgery, and then tumors more than 2 centimeters who need to get neoadjuvant chemotherapy. Actually, the rationale in this splitting is not so much due to the size of the tumor. It was just only because of a trial that has been held with by Professor Tulani, and he said that the patients who are having tumors less than 2 centimeters can get a very good progression-free survival at 3 years, reaching about 98% with going for upfront surgery. And this is the main cause of this splitting. However, this is not now the point of decision to know the size of the tumor. This is not the most important thing. So the first note that the size of the tumor is not that much important. HER2 is very important in order to decide the treatment. So if we decided to start the patient on surgery, then according to the pathological status of the tumor, we are going to say the patients who are having node negative disease and T1 disease, they can go only for paclitaxel for 12 weeks together with trastuzumab. If the patient is having a tumor more than 2 centimeters, still node negative, we can give 6 to 8 cycles of chemotherapy plus trastuzumab and continue the trastuzumab for 1 year. And if the patient is having a node-positive disease, so we should start with the TCHP and continue the trastuzumab, pertuzumab for a period of 18 months, which is 1 year. So what about patients who are node-positive? In patients who are node-positive, as we all know, we should be starting the treatment with neoadjuvant chemotherapy, and then after that, we should assess the pathological response of the patient. And according to the pathological response, we are going to decide whether this patient is going to continue on the same treatment in the neoadjuvant setting or to be shifted to something else. And as you can see here, the patients who have a partial pathological response, or residual invasive disease, in the ESMO guidelines were given TDM1 for 14 cycles. Just in a few minutes, I'm going to revise the criteria, the Catherine trial outcome, where the patients who have been developing partial pathological response after neoadjuvant TCHP were randomized either to trastuzumab or to TDM1. And if you see here, we'll find that at 3 years, we have an invasive disease-free survival improvement of 11.3 months. And based on this trial, TDM1 was approved for the adjuvant setting in patients with partial pathological response. So till now, we have been seeing that we are mainly talking on the pathological response in deciding the treatment plan of the patient. And the TDM1 gave us this improvement. So can we give a patient who is HER2 positive chemotherapy-free protocol and get a good pathological response? I'm going to review with you a few trials, old trials, but they are going to give us some insight. So in these patients who are HER2 positive breast cancer, there was a trial called the Christine trial. It's an old trial where the patients were randomized to receive either TDM1, okay, plus the pertuzumab versus TCHP, which is the classic treatment that we have. And if you can see here the pathological response, you'll find that the patients who received the TDM1 plus trastuzumab had about 40% pathological response compared to 58% for patients who have received TCHP. So this means that we still have 40% of our patients can get into a complete pathological response using TDM1 plus trastuzumab, which means that we are chemotherapy free. And the most important thing is that the groups of patients who have received pathological CR, either by the TCHP or the TDM1 plus pertuzumab, they both did the same. Look at the curve, they are doing the same. Okay, so this is very important to highlight this point. Sorry. Another trial, which is the ADAPT trial, where the patients who are hormone receptor negative and HER2 positive were randomized to either to receive trastuzumab, pertuzumab alone, or trastuzumab, pertuzumab plus paclitaxel. Actually, this trial showed that the pathological response rate was actually so much higher in the patients receiving paclitaxel compared to those who are not receiving paclitaxel. As you can see here, 90% versus 34.4%. And that's why this trial closed after a recruitment of only 100 patients because of these results. But when they did the final analysis, they found that still the patients who got to pathological CR were doing the same for those who have received the TDM1, the trastuzumab, pertuzumab, and those who have received the paclitaxel together with the trastuzumab, pertuzumab. And this brings us to a very important conclusion, is that the key in the disease-free survival and the survival of the patients is the pathological CR. So we need to get this patient into pathological CR by any means. Once the patient reaches the pathological CR, we are going to get a good disease-free survival. So this is a sub-analysis of the patients who were defined as HER2 positive in the ADAPT trial after doing the BAM50 analysis. And if you look here, we'll find that 72% only were found to be actually HER2 enriched. And you can find here that 6% were found to be luminal. 9% were found to be basal. And there were 12.7% missing. And if we look here at the pathological complete response, we'll find that probably the patients who were basal didn't ever reach pathological complete response. The patients who were HER2 2+ by immunohistochemistry and came positive by CISH also, they were not very good responders on the pathological CR. So we now have 2 points that some patients we are HER2 enriched by PAM, they were found to be not HER2 enriched. And the other thing is that the patients who are having an immunohistochemistry of 2+ and positive by CISH, usually they are doing worse than the patients who are HER2 enriched 3+. This is the first point that I want to highlight. So another trial, the ADAPT trial, still HER2 positive, hormone receptor positive. برضو احنا we are searching how to make the patient chemotherapy free. So these patients were randomized to receive either TDM1 plus or minus endocrine treatment versus trastuzumab plus endocrine treatment. If you look at the pathological CR, you will find that with the TDM1, we have about 41% reaching pathological CR compared to 15% to the trastuzumab alone. So the pathological CR with TDM1 alone together with endocrine treatment is about 40%. And as you can see, that pathological CR equals improvement of progression-free survival. Okay. The last thing that I want to highlight also in the ADAPT trial, in this trial, there was a biopsy taken from the patients after 4 weeks from the start of treatment. And they assessed the Ki-67 drop in these patients after 4 weeks. And it has been found that there is a great correlation between patients who reached a drop in the Ki-67 percent more than 30% with the pathological response. And they also found that the patients who are BI3K wild did much better regards pathological response compared to the patients who were BI3K mutant. So what I want to conclude from this is that still in the HER2-positive population, which is a very, very tough population for us, and we know that prognosis is not bad, we can reach pathological CR in a selected HER2 population. So there is, inshallah, in the future, a hope that this selected population with HER2-positive can get chemotherapy-free neoadjuvant treatment, and we can define them by patients who are PI3K wild, patients who are HER2 enriched 3+, and patients who have received a pathological improvement in the Ki-67 in the first 4 weeks. This is according to the trials that I have been discussing. Another idea that I feel it brilliant, which was introduced by the Spanish group, which is the FERGAIN trial. The FERGAIN trial did a very, very amazing thing. They randomized the patients to receive either TCHB, HER2 positive, زي ما احنا متعودين for 6 cycles, أو إن احنا ندي العيانين دول trastuzumab, pertuzumab only for 2 cycles. And then we get at the time after 2 cycles, we go for a PET scan. Those who are having a good response with the PET scan continued with the pertuzumab, trastuzumab alone, and those who didn't get a response, they went back to the TCHB. Again, after the end of the 6 cycles, at the time of surgery, those who got pathological CR continued على pertuzumab, and those who didn't got pathological CR went to the TCHB again. يعني باختصار ان العيانين دولت were randomized to the standard of care which is TCHB for 6 cycles versus ان احنا نبدا بالهرسبتين بيرجيتا alone for 2 cycles, assess the response. good responders بيكملوا هرسبتين بيرجيتا، الباد بيرجعوا للكيموثيرابي، واجين عند time of surgery الجود بيكملوا هرسبتين بيرجيتا والباد بيرجعوا للكيموثيرابي. ولو بصينا بقى على الريزلتس بتاعت الترايل we'll find it like that. So So we find that the responders with the PET scan were about 79% of the patients, and three-fourths of the patients were getting a good response with the PET scan. And what is most important is that those patients who have been responders on the PET scan and have been reaching pathological CR, if you look here at the disease-free survival, you will find that we have a 3 years invasive disease-free survival, which is very high, up to 98.8%, and 99% تقريبا, without touching these patients with chemotherapy and just with using the molecular imaging, which is PET scan, which is available everywhere. So this is a way how we can pick patients who can be sensitive only to the Herceptin project. So this is regarding the HER2 positive. Quickly, I'm going to go through the HER2 negative hormone receptor positive breast cancer. As we all know, in that this group of patients for the luminal A-like, if the patient is low risk, we'll go directly to adjuvant chemotherapy. High risk patients need chemotherapy, and the luminal B-like, they need chemotherapy from the beginning. The question now is that which patient needs chemotherapy and which patients need escalation more than the chemotherapy? So in order to answer this question, I'm going to discuss with you the role of CDK4/6 in the adjuvant setting for hormone receptor positive breast cancer. So let us have a look at the monarchE trial. The monarchE trial randomized patients who are at high risk. For the sake of time, I'm going just to put this. These are the criteria of inclusion of the monarchE so that we will not forget them. Patients with having more than 3 lymph nodes, 4 or more, or patients who are having 1 to 3 lymph nodes, either T3 or grade 3. These are the inclusion criteria of the monarchE, and they are all based on the clinical and the pathological assessment of the patient. So in this trial, 37% of the patients were receiving neoadjuvant treatment and 60% received adjuvant treatment. So let us have a look at the invasive disease-free survival. We'll find that the patients who have received abemaciclib in this group has an improvement of about 7 months or 7.6, and in the distant disease-free survival, still we do have an improvement of about 7 months. So this means that this group of patients benefited from the addition of CDK4/6 in the adjuvant setting with about 7 months improvement in the disease-free survival. This is the Natalie trial, and it's having the same concept. Just for the sake of time, I'm going to go for the BRCA population. Comes here the question of if we have a patient who is hormone receptor positive and is BRCA positive at the same time, what should we do? Should we go for abemaciclib or should we go for olaparib? So let's quickly discuss the criteria of the Olympia trial. Olympia trial was a trial في الأساس started for triple negative patients, and the inclusion was a patient with a tumor more than 2 centimeters or node positive. ده في patients who did not receive new adjuvant. For new adjuvant, any patient receiving new adjuvant and with a residual disease was liable to be included in the Olympia trial. For the hormone receptor positive, who represented about 18% from the population, the criteria was in the adjuvant setting, any patient with more than 4 lymph nodes, and in the post-new adjuvant, any patient with residual disease using the CBS EG score. Sorry, there is no time to discuss the score. So these are the inclusion criteria of the Olympia. So let us have a look here at the improvement. If we look here at the invasive disease-free survival, we'll find that the patients who have received olaparib has an improvement of about 7 months in the invasive disease-free survival and about 3.4 months in the overall survival, and it's the first time to say something about overall survival here. So the only piece of evidence that I want you to remember from the trial is that here we do have an improvement in the overall survival using olaparib in this setting. The other question, so I do have a patient who is hormone receptor positive and is BRCA positive. So how I'm going to manage this patient? This is a sub-analysis from the Monarchy E trial. And if we look here, we'll find that the patients who are BRCA 1 and 2 positive, they still benefited from the use of the CDK4/6 in spite of being BRCA positive. So there is no contraindication or there is no deleterious effect of the BRCA on the effect of the CDK4/6. This is the first thing that we need to know. So how are we going to do for these patients? So let us quickly, how much time is there? Okay. So if we do have a patient and this patient from the beginning is after adjuvant, I mean that the patient is upfront and this patient is having more than 4 lymph nodes, okay? So if we are thinking about this patient for the adjuvant treatment, more than 4 lymph nodes fits into the criteria of the Monarchy and fits under the criteria of the Olympia, صح? So if you are thinking about the response, the Olympia is giving an overall survival. So any patient with lymph nodes more than 4 and is BRCA positive, we are going to give olaparib, okay? So 1 to 3 lymph nodes fits onto the criteria of the Monarchy, but not in the criteria of the Olympia. However, the FDA approval, the EMA approval بتاعت olaparib approved this for this indication. So still we do have evidence that patients with lymph nodes 1 to 3 lymph nodes can go for adjuvant olaparib. ده كده for the patients who are upfront surgery. What about the patients who receive new adjuvant? الموضوع بقى في new adjuvant slightly complicated علشان the inclusion criteria of the two trials مختلفة شوية. So in patients who are new adjuvant, there is a lot of debate about this, but it came في الآخر that we can give them sequential. We can give one agent followed by the other. So can we give the agents together at the same time? We don't have evidence of the safety, so we are not going to do this. But what we can do is that we are going to start with one of them and sequence with the other. To start with olaparib or abemaciclib, we'll go back to the criteria inclusion of the Monarchy trial. We'll find that the CDK4/6 was allowed until 15 months after the surgery, while on the Olympia trial, olaparib was allowed for 2 months only after the surgery. So based on this, we are going to start with the olaparib, followed by the abemaciclib if we are going to sequence both agents. مش هنلحق نكمل. طيب كده احنا يعني we discussed the hormone receptor positive. comes بقى الدايليما بتاعت triple negative. I will tell it just in few minutes. طيب في التريبل نيجاتيف السيتويشن يعني شويه more complicated الحقيقه. So for patients with T1 pathological node 0, we are going to give adjuvant chemotherapy Xeloda, as we all know. In patients with pathological T2 tumor اكتر من 2 centimeters with positive lymph nodes, we are going to give adjuvant chemotherapy followed by 1 year of olaparib according to the criteria of the Olympia trial. So في الجروب دوت we don't have في الادجuvant setting we don't have a problem. Node positive we are going to give olaparib, node negative we are going to give a chemotherapy. Okay, so what about the patients who are stage 2 and 3? في البيشنتس who are stage 2 and 3 طلعت لنا بقى الترايل بتاعت الاميون ثيرابي اللي هي الكينوت 522 اللي هي كانت الانكلوجن بتاعتها البيشنتس اللي هم stage 2 و 3 they receive new adjuvant pembro followed by surgery followed by adjuvant pembro. Okay, لو البيشنت reach pathological CR هنcomplete 1 year of pembro and according to the trial this will improve the progression-free survival of the patient. نيجي بقى للمشكلة بتاعة البيشنتس اللي received neoadjuvant chemotherapy and pembro و still they have no pathological CR. الحقيقة إن المجموعة ديت كان فيها مشكلة كبيرة جدا. هنلاقي إن 35% من البوبيليشن دي من البيشنتس died at 36 months despite of الادجuvant pembro. وده خلانا نضطر نرجع مرة تانية ونقول إنه الجروب ده من البيشنتس if they are BRCA positive we can give them olaparib with an improvement of survival. فإذا برضو معلش دي آخر سلايد هنقول القصة دي تاني. So if we have a patient stage 2 or 3 and the patient is triple negative and BRCA positive, if the patient reach pathological CR after the pembro with the chemotherapy, we can complete 1 year of immunotherapy. If the patient didn't reach pathological CR يبقى احنا بنتكلم في ان انا عندي I'm going to lose about tilt البيشنتس بتوعي within 3 years. يبقى لازم intervene with something else. So I'm going to add olaparib. طبعا ممكن مع الاميون ثيرابي لان في الميتاستاتيك سيتنج ترايلز بتقول انه الاثنين مع بعض كان دو ويل، يعني السيفتي كرايتيريا بتاعتها كويس. يعني I hope that I didn't went fast because it's a very big presentation. So what I want to emphasize is that in HER2 positive still we do have the window that we can inshallah in the future use chemotherapy free regimens in selected population, mainly those who have reached a very good initial response with Ki-67 and those who are PI3K wild and those who are HER2 enriched 3+. They can have the chance, inshallah, in the future to receive a chemotherapy-free regimen. And if for the hormone receptor positive, we have 2 playing agents, the abemaciclib for the patients who are at high risk and the olaparib for patients who are BRCA positive. And we discussed in short, in triple negative, the role of the immunotherapy and how to incorporate it with the olaparib. Sorry for going fast, but it's a very big lecture. I hope it was informative. Thank you very much. Thank you.
Thank you, Dr. Hanan. Dr. Iman Ali. دكتورة إيمان علي. أنا بريزنت مين؟ Okay. It's my great honor to be here in Bahia Breast Cancer Conference, and I would like to express my gratitude to the organizing committee. You are doing a perfect conference, actually. Now we will, Dr. Iman Ali, consultant of clinical oncology, clinical oncology Qasr Al Aini, Cairo University, will present ovarian ablation magnitude of benefit in early breast cancer.
ده باك فين باك؟ لا لا نكس، انا عايزه ارجع باك. ماشي. هي راحت فين؟
next speaker. Yes.
ايه المشكله؟
عشان هي خلصت.
ابدا منين؟ اول واحده.
حضرتك تبدأي من أول واحدة عادي.
ماشي بس كده، شكرا. شكرا. مساء الخير. I will start with my patient. She's Mrs. S.A. She's 45 years old, premenopausal. She presented to our clinic in February 2024 by right breast lump. She underwent breast sonomammography that showing the evidence of right upper outer quadrant, highly suspicious mass with non-specific axillary lymph node. Biopsy was invasive duct carcinoma grade 2, ER 8/8, PR 6/8, HER2 +1, and KI 6/7, 20%. She had upfront right wide local excision with sentinel lymph node. Histopathology, invasive duct carcinoma grade 2, T2, 2.5 centimeter, N1, 1/5 lymph node with positive lymphovascular invasion. Our patient ended her adjuvant chemotherapy of anthracycline taxane based. Now she presented to our clinic asking for adjuvant hormonal treatment. What is the different hormonal treatment option we can offer to our patient? Tamoxifen for 5 or 10 years, TAB Zoladex or AI Zoladex, and what about the duration of adjuvant hormonal treatment, especially if we give her the ovarian function suppression, and delete, what about the toxicity? Here, I will show the most famous TEXT and SOFT trial. The TEXT trial, post-trial was randomized phase 3 trial. The TEXT trial will randomize the patient to tamoxifen with ovarian function suppression versus exemestane with ovarian function suppression. In the TEXT trial, the median age of the population was 43 years, and 60% of the patient had adjuvant chemotherapy, and 48 only had lymph node positive, and about 85% of the population are HER2 negative. While the SOFT trial, the patient were randomized to 3 arms: tamoxifen versus tamoxifen, ovarian function suppression, and exemestane with ovarian function suppression. In 90% of the population in the SOFT trial, the ovarian function suppression was conducted by LHRH analog. In the SOFT trial, the median age was 43 years old, and 53% of the population had adjuvant chemo, and 35% had lymph node positive. The TEXT and SOFT trial was conducted mainly to answer two main questions. The first one, what is the value of addition of ovarian function suppression to Nolvadex in the adjuvant setting of the premenopausal female patient, which will be answered by the SOFT trial. And the second most important question, what is the value for addition of AI versus tamoxifen to ovarian function suppression, which will be answered by combined analysis of TEXT and SOFT trial by combining the both arm of tamoxifen exemestane. The 5 years follow-up of the SOFT trial was failed to show any survival benefit, any disease-free survival or breast cancer-free survival for addition of ovarian function suppression to tamoxifen in the overall population. Although we have certain subgroup of patients at 5 years of follow-up that show the benefit to ovarian function suppression. The first one is the patient who received the chemotherapy. Those patients had higher benefit from addition of ovarian function suppression to Nolvadex. The patient who received the chemotherapy mostly have higher clinical pathological feature, larger tumor, lymph node positive, grade 3, younger patient. And at the 5 years follow-up, 90% of the mortality and the recurrence was occurred in the chemotherapy group, while 95% of the patient who did not receive chemotherapy was free from any breast cancer recurrence. Again, the patient at 5 years follow-up, the patient who younger than 35 years old, and the patient who maintained premenopausal after the end of chemotherapy, those patients had the highest benefit from ovarian function suppression addition to tamoxifen to tamoxifen. Very important concern that in the SOFT trial, 50% of the population had adjuvant chemotherapy. The recruitment of the patient after chemotherapy was maintained only for the patient who kept premenopausal after the end of chemotherapy by biochemical measurement of estradiol. Those patients had the highest benefit from ovarian function suppression addition by 4.5% improvement, absolute improvement for TAM, ovarian function suppression, and 7% absolute benefit with AI, ovarian function suppression. While the combination of SOFT and TEXT trial proved that there is 28% reduction in the relative risk of the breast cancer recurrence for AI ovarian function suppression versus tamoxifen. At 8 years follow-up of the SOFT trial, the result was in contrast to 5 years follow-up. It's showing a statistical significant benefit for disease-free survival and overall survival for addition of ovarian function suppression to the tamoxifen. And in contrast to 5 years follow-up, the benefit of ovarian function suppression was maintained regardless the chemotherapy was given or not. However, the benefit to the patient who received chemotherapy is much higher here to the patient who did not receive the chemotherapy. The patient who received chemotherapy, the patient who didn't receive chemotherapy, they have 5 to 9 absolute benefit here to ovarian function suppression, while the patient who did not receive chemotherapy had absolute benefit only for 3 to 5%, which is indicating that we have some group of patients with low clinical pathological feature, which does not indicate the adjuvant chemotherapy. Those patients, the ovarian function suppression benefit is very limited, and we can omit for such patients. What about the combined soft and text trial combined analysis at 8 years follow-up? The 8 years follow-up showing there is statistical significant benefit for disease-free survival and distant recurrence-free survival benefit for addition for AI versus tamoxifen in addition to ovarian function suppression. However, they failed to show any overall survival benefit for AI versus tamoxifen versus tamoxifen. However, the follow-up, it was only 8 years and 8 years, and this overall survival data, mostly it is immature data, indicating that the long-term survival or long-term survival of hormone receptor positive early breast cancer, whereas we can see even the late relapse in after 20 years and after 20 years, and even with longer follow-up, we can catch up the overall survival benefit. All our patients has the same benefit from AI versus tamoxifen? No. In the subgroup analysis, we have some group of patients who had the higher benefit and the higher benefit from addition of AI to ovarian function suppression. The patient who had HER2 negative and who received chemotherapy again. Those patients had the highest benefit from the AI versus tamoxifen in the adjuvant setting. The benefit again was maintained again with 12 years follow-up for AI versus tamoxifen in addition to ovarian function suppression in 12 years follow-up as regard again disease-free survival and distant recurrence-free survival. However, the 12 years follow-up was failed again to show any overall survival benefit for AI versus tamoxifen. Again, it is still immature data, and we need more longer follow-up to answer this, to criticize the overall survival benefit, especially that the disease-free survival and the distant recurrence-free survival benefit was maintained at 12 years. The 12 years follow-up showing a very important subgroup analysis justifications that there is certain subgroup of patients who had the higher benefit from AI Zoladex. Although all the patients was benefit, but we have certain subgroup of patients who had the higher benefit. Again, the HER2 negative patient who had adjuvant chemotherapy and some clinical pathological feature like a patient who less than 35 years old, tumor size more than or equal 2 cm and grade 3 tumor. Such patient had statistical significant benefit for AI versus tamoxifen, which clarify which patient in our clinic we should offer AI Zoladex versus TAM Zoladex. Here I will mention two important meta-analysis. Meta-analysis was published by Early Breast Cancer Trialist Collaborative Group. This group is was published many meta-analysis which is characterized by individual patient data for every patient included from different clinical trials, making the result of such meta-analysis published by this group one of the most reliable meta-analysis. The first one was published in 2022, including more than 7,000 patients from 4 randomized patients to assess the difference between AI versus tamoxifen combined with ovarian function suppression in the adjuvant setting. Again, the result of this meta-analysis was compatible with 12 years follow-up of the combined soft and text trial, showing there is statistical significant benefit as regards disease-free survival and distant recurrence-free survival. Again, it was failed to show any overall survival benefit for AI versus tamoxifen. But the overall survival benefit here, it was done after median follow-up only of 8 years. Maybe with longer follow-up, we can catch up this overall survival benefit. This meta-analysis showing that the benefit of AI versus tamoxifen was maintained through the all subgroup, But again, there is certain three subgroup with specific three important information. The first one, that the benefit of AI versus tamoxifen was maintained only in the first 5 years of the first 5 years of follow-up, where the benefit of AI versus tamoxifen was markedly diminished after from 5 to 10 years, even disappeared in more than 10 years. The author explains this difference by that this meta-analysis including 4 international randomized control trials. 3 of them, including the soft and text trial, the ovarian function suppression was given for 5 years, while we have only one trial, which is the ABCSG 12 trial, which is include the ovarian function suppression for only 3 years. This trial, by the way, it was negative study, and the author is justifies that the difference documented at 5 years, it could be due to the difference in the treatment offered to the different patient within the meta-analysis. The second observation, that the benefit of AI was maintained only in the patient with node negative and N1 disease, while the patient with N2 disease was failed to show any benefit or superiority to AI versus tamoxifen, which is not expected and which is not logic. The author explains this unexpected result for N2 disease, that the N2 disease was included only in 10% of the meta-analysis. The second justification, if we return back to the postmenopausal woman, the AI showing superiority to the tamoxifen in all lymph node group, including N1, N2, N3 disease. Even the author here in this meta-analysis combined the result of AI versus tamoxifen in the pre and the postmenopausal woman, and they found that the benefit was maintained regardless the number of lymph node involvement. And by the end, the author explained that the loss of benefit in N2 disease was happened by chance. The third observation in this meta-analysis, that the benefit was maintained regardless the chemotherapy. Again, the magnitude of benefit is statistically significant, evident in the patient who had chemotherapy, while the patient who did not receive chemotherapy had minimal improvement from addition of AI versus tamoxifen. The second meta-analysis was published by the same group. This meta-analysis was published only as abstract in ASCO 2023. This abstract, this meta-analysis including 15,000 premenopausal patients from 25 randomized trials to assess the value of ovarian function suppression in the premenopausal adjuvant breast cancer. This meta-analysis has unique characteristics. The unique in the subgroup stratification of the patient. They stratified the patient in 3 groups. The patient who had no chemotherapy, the patient who remained premenopausal after the end of chemotherapy, either with chemotherapy-induced amenorrhea or by the evidence of estradiol level. And the third group, the patient who enter in menopause after the end of chemotherapy, after the end of the chemotherapy. The primary endpoint was 15 years breast cancer recurrence rate, and 12 and 20 years of cause-specific mortality and all-cause mortality. Again, this paper, this abstract, it was published as abstract. The full paper not published yet. What is the abstract told us? There is, in overall population of the study, over the 15,000 patients, there is statistical significant benefit for addition of AI versus tamoxifen in the premenopausal patient as regard 15 years breast cancer recurrence and 20 years breast cancer specific mortality. However, in subgroup of patients, the patient who did not receive chemotherapy, or the patient who maintained to be premenopausal after the end of chemotherapy, either with estradiol level or the patient who retained menses after chemotherapy, such a group of patients had the maximum benefit from ovarian function suppression, with absolute benefit 12% versus benefit only of 1.3% for the women who enter in menopause after the adjuvant chemotherapy. It is not the only observation. Second one, most important information, that the benefit of ovarian function suppression was maintained regardless the age and regardless the nodal state. However, the benefit was higher in the patient who had lymph node positive than the lymph node negative. As we see here, it is 12% versus 8%, and the benefit in the patient who younger than 45% had higher benefit by 11% than the patient who aged from 45 to 54 years old. which indicating that, and this meta-analysis raised a very important question, that the patient who older premenopausal female patient who enter in menopause after the chemotherapy, the benefit of ovarian function suppression for such patient is very limited, and we can think that those patients will not benefit from ovarian function suppression, whereas the tamoxifen for 5 or 10 years could be more than enough as option for such patient. Again, we are waiting for the full publications to get the full result. The last trial I will mention, all the international guideline, ESMO guideline, NCCN, St. Gallen, ESMO young breast cancer, even Chinese guideline, all these guidelines, they recommend the ovarian function suppression should be offered for 5 years, for 5 years. طب, do we have data to recommend to give ovarian function suppression below 5 years? Yes, we have one important randomized phase 3 trial was conducted at South Korea, including more than 1,400 patients who recruited only the patient who remained premenopausal after the end of chemotherapy by serial ovarian function assessment every 6 months for 2 years after the end of chemotherapy. All recruited patients had received adjuvant chemotherapy, was stage 1 and 3 disease, HER2 positive below 45 years old. They recruit only patients who younger than 45 years old. 55% had lymph node positive, 52% had tumor size more than 2 centimeters, 24% had grade 3 tumor. The patients were randomized to 5-year tamoxifen versus 5-year tamoxifen combined only by 2 years of monthly Zoladex. The primary endpoint is disease-free survival. Secondary endpoint was overall survival. The 8 years follow-up of such a study was published in 2023. Again, this study showing that there is statistical significant benefit for disease-free survival for the patient who received 2 years of ovarian function suppression versus tamoxifen alone, with absolute benefit of 5.3%. However, this study failed to show, again, overall survival benefit for ovarian function suppression to addition of ovarian function suppression. However, the soft trials, they show that at 8 years follow-up, there is overall survival benefit for addition of ovarian function suppression when we use 5 years of ovarian function suppression. But in this study, the 5 years overall survival in both groups was exceeding 95%, indicating that maybe with longer follow-up, we can get the overall survival benefit. What does this study give us? This study give us idea or raise the possibility about do we have certain subgroup of patients who will benefit from 2 years of ovarian function suppression, and is not all our patients need 5 years ovarian function suppression. And the result of this study as well give us as a window in our clinic for patients who had severe could be the patient who had severe toxicity or non-compliant to ovarian function suppression, or even the young female who want to get pregnant, whereas we can stop the ovarian function suppression after 2 years. We are waiting for longer follow-up, and we waiting for further investigation to assess such patient. Again, I will revert back to my patient. What is the adjuvant different hormonal treatment option would we offer to our patient? Again, if you prescribe the ovarian function suppression, please, you have to tell your patient about the nightmares of toxicity about the ovarian function suppression, especially the osteoporosis, skeletal related event, vaginal dryness, dyspareunia, fatigue. Even there is new data about the cognitive disorder with the patient who received ovarian function suppression. Yes, thank you.
Thank you, Professor Iman, for this elegant presentation. And now I want to introduce Professor Maha Yahya, Assistant Professor of Medical Oncology, NCI. The topic is recent update in the management of advanced triple-negative breast cancer.
البوينت ده كده في سبوت لون بيظهر اهو. نكست
Assalamu alaikum. Thanks, Chairperson. Thanks, Dr. Amini, and thanks for Bahia for inviting me. Today we'll discuss the recent updates in the management of metastatic triple-negative breast cancer. Unfortunately, metastatic triple-negative breast cancer is the worst subtype of breast cancer and the worst prognosis. Until 2016, the median overall survival for metastatic setting is 14 months. This is due to many factors, like high percentage of germinal BRCA mutation with increased percentage of PD-L1 receptor expression and high tumor mutational burden. These are the ISMO guidelines for metastatic breast cancer. In metastatic breast cancer, we should try to search for the prognostic marker. First one is PD-L1 receptor. Triple-negative breast cancer has affinity for targeting by immunotherapy due to high percentage of tumor-infiltrating lymphocytes, high expression of PD-L1, and non-synonymous mutations. We have two options for patients with PD-L1 receptor positivity, either atezolizumab plus nab-paclitaxel or pembro plus chemotherapy. This approval after the two studies, positive studies in Passion 130 and Keynote 355, both trials addressing the first-line immunotherapy in metastatic triple-negative breast cancer. There are some differences between the two studies. First one, in the Impassion, the disease-free interval more than 12 months, while in the Keynote 355, 6 months. And this gives the Keynote more patients with, because the patients between the 6 and 12 disease-free interval account 22% of patients, sorry. The other difference between the two trials, the chemotherapy backbone. In the Impassion 130, we have only nab-paclitaxel, while in the Keynote, we have nab-paclitaxel or paclitaxel or gemcitabine carboplatin. The third difference between the two trials, the way to assess the PD-L1 receptors. In the Impassion 130, we have the immune, to detect the immune cells by immunohistochemistry, while in the Keynote, the detection by the CPS score, combined positive scoring. Although these differences, both trials had improvement in the progression-free survival and overall survival. In the Keynote 55, only in the patient with CPS more than 10. Also improvement of progression-free survival, almost the double between the chemotherapy alone and adding immunotherapy. These trials coming the immunotherapy at the first line treatment for patients with metastatic triple-negative breast cancer with PD-L1 positive. The other therognostic marker is BRCA mutation, the germline BRCA mutation positivity. We have either to give the patient chemotherapy with platinum-based treatment or to start PARP inhibitor as first line. We have also two trials approving PARP inhibitor in the metastatic setting, Olympian trial for olaparib and BRCA for talazoparib. Both trials testing the PARP inhibitor versus chemotherapy of physician's choice in patients receiving at least one line of chemotherapy before. Both trials had improvement in progression-free survival and also a good response rate. What about platinum salts? Platinum salts tested in many trials in patients with triple-negative in general, but the TNT trial addressing the subtyping the patient to BRCA mutation or not from the first, either to start carboplatin or to start docetaxel. There is higher responses rate for BRCA mutation, triple negative breast cancer receiving carboplatin at the first line. If we don't have BDL1 positivity and germline BRCA wild type, the options to start chemotherapy, we should put in our consideration the previous treatment exposure, the disease presentation, either it is in visceral crisis or not, the disease-free interval, and the patient consideration. If we have patient with visceral crisis, we will go for combined chemotherapy with anthracycline and taxanes-based combination. Alternatively, we should give taxanes plus bevacizumab or capecitabine plus bevacizumab. If there is no visceral crisis, we go for the monotherapy treatment. What about the second line? Second line, the antibody drug conjugate lies in the second line treatment for metastatic triple negative breast cancer. We have many targets for the ADCs. First one, sestuzumab vedotin, it is a TROP2 directed ADC. It get the approval after the ASCENT phase 3 trial, testing the sestuzumab versus treatment of choice, of physician choice in patients receiving at least 1 or 2 chemotherapy for the metastatic disease. There is improvement in progression-free survival, at least 2 months and 5 months overall survival, and this is better, or could be, yeah, it is better something in patients with second-line metastatic triple negative disease. The second ADC, it is trastuzumab deruxtecan, HER2 directed ADC. It is tested in the Destiny Breast 04 to test the TDXD versus treatment of choice, either capecitabine, erlorbin, gemcitabine, or paclitaxel in patients with HER2 low positive disease. Patient had an improvement in the progression-free survival and overall survival, but we should put in our consideration that the number of patients with HER2 negativity in this trial, only 58% of patients, 40 patients received TDXD versus 18 patients' choice. And this gives us questions how to sequence the ADCs in the patient with HER2 low, either to start with sestuzumab or with TDXD. This is questions raised in the ESMO, and the answer in favor of starting with sestuzumab before TDXD, because we had a solid data with sestuzumab. Fortunately, we have a very good evolution of the treatment of metastatic triple negative breast cancer in the last years, with introduction of a lot of surrogate drugs, with improvement in the survival of patients. And thank you.
Okay. Thank you very much for Professor Dr. Amani Hilal في الحقيقة for this very kind invitation. And we are going to open the discussion because I don't see Professor Dr. Loay. I was supposed to introduce him, but I think, thanks God that some of the presenters are still here, like Professor Dr. Iman Ali. Thank you very much for what you have said. And please tell us, your 45 years old woman, what did you choose for her as adjuvant therapy, and for how much? I would like to have, please.
Thank you, Dr. Hana. For my patient, she's 45 years old. Usually we started with AI Zoladex for our patient. That's showing the highest benefit هنا, especially my patient's lymph node positive. Young patient is 45 years old. And we are still to the international guideline that recommends that the ovarian function suppression should be continue for 5 years and for 5 years. In some patient who had severe toxicity, we may consider such patient to stop ovarian function suppression.
Yes.
And we shifted back to tamoxifen.
Actually, I'm going to take this opportunity to ask Professor Dr. Hiba, our dearest professor in oncology, about actually, if your patient is 45 years, and I'm going to check for her, as Dr. Iman said, I'm going to check her serum estradiol. I know that 5 years are not the best thing for her, actually, because we all know that after chemotherapy and after this, am I going to make her serum estradiol during her ovarian function suppression? What's your opinion? Please tell us.
So, thank you دكتورة هناء وأهلا بيكي طبعا ومشرفة المنصة. انت قاعدة قلقانة ومش قادرة تصبري على الكرسي زيي من ساعة ما سمعتي حكاية 5 years ovarian suppression in the premenopausal lady, and we know in a daily life how much it is very difficult and tough, and sometimes a psychologically and socioeconomic problem for the patient as well. فأنا بس عايزة قبل سؤال حضرتك أشير معلش كل اللي قاعدين, it's worldwide 2 years suppression by ovarian function suppression. If it is temporary by Zoladex, so please everybody, just 2 years. The benefit after 2 years, because أنا في many studies, in the benefit of the after 2 years, the survival curve and disease-free survival is very, very, very overlap. So they wait and see after a while. But if we do 2 versus 5, 2 is very enough and it is worldwide. I'm telling this is why, because of 2 things, دكتورة إيمان وطبعا كل الدكاترة الشاطرين اللي زيك. If the patient above the 45, so no need for over suppression, because she is naturally will be post-menopause at the age of near 50, even though كمان more and above she received chemotherapy. When it is very young, this is very not good for her physiology to give her extended ovarian suppression. And sometimes here in Egypt and in many modern cities, the age of marriage and getting a child is 30 something. So it is just 2 years. And more above, I will support myself in this very particular point, that the early pregnancy effect, we advise them to get pregnant when they are married and have to plan their family. The early pregnancy effect is sometimes protective to her. So this is a 2 factors that contradictory. So right to your question, if I have a patient and she is 45, I may choose for her tamoxifen with 2 years of ovarian suppression. And if she have a lymph node, the patient with 1 lymph node, maybe more 3 lymph node or grade 3, I may choose aromatase inhibitor as well and ovarian suppression. عايزه اقول حته براكتيكال جدا بس احنا بنقولها في المحاضرات وبننساها. ما ينفعش العيانه تكون بريمينوبوزال وادي لها اروماتيز انهبيتور وزولادكس وبكره الصبح اقول هي اندر بروتكشن. على فكره يعني either I proceed by some ovarian suppression and tamoxifen, or I do estradiol level, or I do aromatase inhibitor, because aromatase inhibitor itself is not in the right physiology of premenopausal lady. So again, this is very tricky point.
Very tricky situation, actually. Actually, for the I'm very thankful for you, Professor Dr. Heba, because I'd like to this question to be answered by Professor Dr. Heba, اللي هي أستاذتنا كلنا في الحقيقة دكتورة إيمان. وأنا طبعا بشكرك جدا على اللي أنت عملتيه ده، كان رائع. يعني أنت what you have went through many things، لكن احنا في الحقيقة في الريل حياة بنشوف حاجات مختلفة كتير. Also for the window of opportunity and Dr. Hanan, you gave us many things that I would like you to highlight here for us. How important the Chi-67 to be done and not to ignore it completely in our pathology. You have said two kinds of trial that depends on as a window trial, window of opportunity, and you supposed to have a Chi-67. That because I am here and with the Bahia dear friends, that they don't do the Chi-67, and really I don't know how do you know the luminal B from luminal A. Sometimes I have to think of these things. Please give me your comment, Dr. Hanan.
breast cancer we should go for Ki-67 في الأول to identify luminal A. فاحنا we need في العيانين اللي هم luminal breast cancer to go for Ki-67. This is very important so that we can identify which patients we can omit chemotherapy and we give hormonal treatment only في adjuvant setting, especially في الناس اللي هم عندهم tumors less than 3 centimeters, those who are node negative. But this is very important point in our practice. In the research في الحقيقة إنه leading في الكلام ده كانوا الجيرمان society هم اللي في الأول they started thinking of the importance of Ki-67 والايرلي suppression او الايرلي دروب بتاع الليفل بتاع Ki-67 والايفكت بتاعته على الاوتكم بتاع العيانين بعد كده، وهم they are taking it as a clue ان هم personalize the patients. يعني احنا we can check for the Ki-67 then هم عاده بيعملوا ري بايوبسي بعد 2 weeks الكلام دوت، يعني هم ده البراكتس بتاعهم وبيشوفوا Ki-67 لو دروبت اقل من 30%
Yes.
بيقولوا ان البيشنت دي probably she's going to get a good pathological response. وفي بعض يعني عندهم ترايلز كتير قوي على الراندمايزيشن بتاعت البيشنتس دول بعد الدروبينج اقل من 30% للكيموثيرابي او الكيموثيرابي containing regimen versus النون كيموثيرابي containing زي ما احنا كنا بندسكس، عشان نقدر نفتح الويندو للجروب ده من البيشنتس انه maybe at the time we can omit chemotherapy. طبعا it's very very important regards الانيشال والدايناميك. يعني احنا initially في التشيكينج والدايناميك افكت بتاع التريتمنت بتاعنا على Ki-67 الحقيقه.
Actually, we are going to raise your voice to Bahia to do the Ki-67. Okay. Also, I would like to have another thing. طب حضرتك تحبي تقولي حاجه يا دكتوره؟ اتفضلي.
البيشنت لما بتبقى جايه بسترونج هرمونال ريسبتور بوزيتيف ديزيز وسمول تيومر وليمف نود نيجاتيف، Ki-67 has a clinical utility in treatment decision. لكن العيانه ما بتكون جايه بانتو ديزيز whether she has a low Ki-67 or high Ki-67, by definition she needs chemotherapy. That's why it's not that widely used among these patients. So the clinical utility in our practice ما بتخليناش نعمل Ki-67 for all the luminal breast cancer patients.
تمام.
That's why.
عارفه حضرتك انا طبعا مقتنعه جدا بوجهه نظر حضرتك، بس برضه عاوزه ارفع صوتي. عاوزه ارفع صوتي بهذا. أنا برضو هقول لحضرتك على حاجة كمان. Actually, we don't need. Actually, I'm gonna give you a chance right away, but I would like برضو to give a hint about that most of the patients who were giving either chemo or hormonal or chemohormonal, I think Professor Dr. Iman, they had done Oncotype DX. You see in your analysis, and that's why the presence of Oncotype DX for these patients is going to pick and choose for you who is going to choose at least first chemo or to omit, and that's why it's not surprising. Patients who did not have chemo, some of them they are better, but this is not logic. But it will be very logic because they have done the Oncotype DX. Actually, we can continue the discussion. We have really good time. But Anna, I am very proud that my dear colleague, Professor Dr. Luay Asim, and I would like to engage him in the discussions. He's our superstar in Asr Al-Aini, and he is assistant professor. And I think he is going to give us please tell us.
Thanks a lot, my dear Professor Dr. Hana, and thanks for the great panel. Thank you all for attendance, and thanks to Dr. Amani Hilal for organizing this magnificent meeting. I'm sorry for my late show up. I will present the case or how we approach the idea or the situation of pregnancy in breast cancer survivors. And is it a true risk or opportunity? These are my disclosures. And I will start by one of my patients. She's a 40 years old lady, married, and a mother of one girl. 3 years ago, she had left breast cancer, pathological T2N0, where she did breast conservative surgery. It's an ER positive, HER2 negative disease. She received the surgery, the chemotherapy, radiation therapy, and she was kept on adjuvant tamoxifen. She wanted to get pregnant, so she showed up at her gynecologist and asking him, is it okay for me to get pregnant? And he told her that she shouldn't get pregnant for the rest of her life because she had an ER positive disease and pregnancy would necessitate that a huge rise in the level of estrogen and progesterone, which were positive in her tumor, and this means a very good chance of having recurrence. She presented to me with that situation on how and when and if she could ever get pregnant. That is the question. And despite what her gynecologist really said is logic, we are treating her with anti-estrogen. And pregnancy is the highest possible situation where she got high levels of estrogen in her body. So if you think about that, what her gynecologist said is very logic, but it's not backed up with evidence. So we're not sure whether if she got pregnant, she would have a high risk of recurrence or not. So the question is addressing this point important to patients? That's the first question. So why bother about that? We just tell her no. Or we just don't bother about the subject because it's not very important. Breast cancer patients, they care more about being cured from breast cancer, and they don't care a lot about getting pregnancy or preserving fertility. Is that true or not? That's a study that went through the point of breast cancer or patients with cancer in general. We're sorry that the animations is not working, but the idea is if you interview those patients, 918 women, around 213 of them were breast cancer. 73% of them already had children. However, around half of all the interviewed said that they wanted children. And, okay, I'm sorry that the animation is not working, but again, another survey of breast cancer patients specifically concerned about fertility. The whole number, again, 73, who described themselves as seriously concerned about that, 57%, and who did not comply to their treatment because their concerns that their treatment will affect their fertility are about 1/3. So if we do not address that from the start of her treatment journey, we're going to lose some very effective treatment because we do not care about one important subject that 1/3 of the patients, they care about even more than getting cured. So, the second point, does having breast cancer affect the fertility? And how is that? That's a huge Scottish database from UK, more than 23,000 women. All of them got cancer before the age of 40. And the result is that cancer survivors, cancer in general, had 38% less pregnancies than expected from other counterparts who did not have cancer. breast cancer ranked second among the causes of cancer-induced infertility with 64% less pregnancies. How does that happen? We can speculate many causes. Age, because cancer comes with age, so progressive age will affect fertility, chemotherapy, long-term endocrine therapy, and unuse of the common fertility preservation techniques. Age is an important factor. To many breast cancer oncologists, age is the most determinant factor regarding fertility. And if you ask anyone who is not medical, they are very aware of that. With progressive age, the ovarian reserve, the follicles that can cause ovulation and pregnancy, they are less. And the second is chemotherapy. And please note that the type of chemotherapy makes difference. If you look at the first part, that's CMF. We do not use it frequently now. It's much less toxic than the anthracycline taxane on the hair, on the bone marrow, but it's more toxic on the pregnancy, on the fertility, compared to any other regimens. And please note that on the left-hand side, the patients who are less than 40 years, they carry much less infertility risk compared to those who are more than 40 years. Whatever the regimen, if you look at CMF, for example, you can reach up to 100% risk of infertility with 6 months of CMF if she's more than 40 years, but if she's less than 40 years, the risk is lower. Again, AC times 4, the short course, carries much less infertility compared to all other regimens, and the anthracycline taxane, the one that we use in the lower, that's a 6 months regimen indeed. Again, it causes intermediate risk of infertility. But if you look at those with more than 40 years of age, for example, it is significant. 3/4 of them have ovarian failure because of chemotherapy. So, if you look at the ESMO guidelines and you look at the upper part, you will give a gonadotoxic treatment. You should ask the patient first. If she wishes to preserve fertility, then you go to the next part. Do you have a time of 2 weeks before starting treatment or not? If you have enough time, you should do ovarian stimulation and preserve the ovum. If you do not have enough time, what to do? Ovarian tissue. You can do that in a single day. You just put a laparoscope, take a part of the ovary and preserve it. What if the patient do not want to preserve the fertility? You ask her about, or you consider preservation of the ovarian function. Because ovarian function is not only fertility, it's also the hormonal function. And in such case, for example, in ER negative patients, you have no problem with the hormones. So you could preserve the hormonal function by using LHRH agonist during chemotherapy. One important point that even if your patient was offered preservation of the ovum or preservation of the ovarian tissue, you should start LHRH agonist with chemotherapy to preserve enough follicles, because many patients would depend on the preserved follicles and the preserved hormonal function, not only on the frozen one. So you can do the regular induction of ovulation protocol, that's on the left and upper hand side, where you have to wait for day 2 of the cycle, then start the stimulation, and you follow up by ultrasound and the blood hormone monitoring the maturation of the follicles. On the other hand, there is another protocol using specifically letrozole, what we call controlled ovarian stimulation protocol. Here you have 2 important edges. First, you have less estradiol level, and second, you can start anyway in the cycle. So with that, you could reduce the amount of time you wait to get the ovum, less than 2 weeks. So, is it safe to use letrozole there? Well, I think that's not a very difficult question. We use that all through, but the important is it effective in getting enough ovums and hence enough babies? So on the left-hand side, the number of oocytes, it's typically the same as compared to other modules of ovarian stimulation. On the right-hand side, you have significantly lower estradiol level if you use letrozole in ovarian stimulation, the so-called controlled ovarian stimulation protocol. So, a very tricky question is, you would preserve, otherwise, other than the ovum, you could preserve the tissue. Is it safe to do that? Couldn't you have a microscopic disease? We are treating patients with chemotherapy because we know they have a microscopic disease all over their body. So couldn't she harbor some microscopic disease within the ovarian tissue that we are preserving? Again, that is a theory. And by evidence and by histopathological examination of that preserved ovarian tissue, we have a very low risk of patients of having a microscopic disease in the ovum in patients with stage 1 and 2 breast cancer. You have an intermediate risk, again, if she has stage 4, for example. And you have, of course, very high risk if she has leukemia or lymphoma. That's a high risk to have. Again, we do not have, if they carry higher risk of relapse, because ovarian tissue preservation is a relatively newer technique, and you do not have long-term data to validate this point. So let's look into deeper. Many patients, they have problems with the spontaneous ovulation. So they will have ovarian stimulation and in vitro fertilization. That entails even more hormones, not only that of pregnancy, but that with ovarian stimulation. Does that increase the risk more or not? That's a good study that looked into if they used the pregnancy, if the pregnancy happened spontaneous, or if it happened with ovarian stimulation. And here, they limited to controlled ovarian stimulation. So there is no very high levels of estrogen. And again, the survival, as you can see, is the same. That's a meta-analysis that looked into many studies. And if you look at the hazard ratio, it's surprisingly better in patients who went for pregnancy. We don't know why is that. That might be biased because of a survivorship bias. But again, numerically, the relapses are less in those who went for pregnancy compared to those who did not. So what if you restricted for ER positive? We do not care if patients with ER negative disease receive hormones or not, or have high levels of estrogen or not. What we care about more are those with ER positive disease. And if you limit it to the ER positive study, this study presented by Dr. Matthew Lambertini and colleague, of predominantly European patients, and again, survival is the same between patients who did go for pregnancy and this who did not, and that's all of them were ER positive. So more estrogen, but not more relapses. So what if they had a BRCA positive disease? Well, why do we care about BRCA positive disease? Because they have a higher risk to have a second cancer, third cancer, ovarian cancer, many other cancers. So would they have higher risk of recurrence if they did have pregnancy? On the left-hand side, you don't have a problem. If you look at the curve and you think there is a difference, again, the pregnant patients had higher survival. Again, less relapses on those who get pregnant. And if you divide, again, the animations were messed up, but if you look with specific BRCA mutation, it looks like the BRCA2 patients had a little bit more relapsed when they got pregnant, and that can be explained by most of them were BRCA positive. Again, we do not have enough data to support or not support pregnancy in BRCA positive patients, but if they had completed their family, they go for the ovariectomy. If they not, they should be allowed to complete their family, and then they could go for ovariectomy. So the problem is that our patient, the one that she presented to me and to my gynecologist colleague, she was ER positive disease under adjuvant endocrine therapy. And that's a very tricky point, because to get pregnant, she will have to stop the adjuvant endocrine therapy, and to get pregnant with much more hormones. So we have a double hit here, that we will stop the adjuvant endocrine therapy, which is known to improve the survival, and we will get her pregnant, which is known to increase the hormone levels. Is it safe? Well, that was asked in the positive study. So positive study was not able, of course, to randomize patients into get pregnant or not to get pregnant, but the idea is they had to stop after completing 18 to 30 months of endocrine therapy. So they should have done surgery and kept in endocrine therapy for some time, and that time would be 18 to 30 months at least. If they wanted to get pregnant, they're included in the study, stop the endocrine therapy, whatever it is, tamoxifen or ovarian function suppression or others, stop it and have a 2-year window to get pregnant. And then come back to the endocrine therapy again to complete either the planned duration, or they were allowed, of course, to have an extended adjuvant duration, according to the physician. So how do we know that of course, they were monitored to assess relapses. So how do we know that this relapse rate is high or low? They had a synthetic control arm. What is meant by synthetic control arm? That you check similar patients who are treated in the soft and text study with similar disease characteristics to those in the positive study, and you monitor which of them would have more relapses. And that's the answer. On the left-hand side, that's the pregnancy outcome. More than 70% of the patients got successfully pregnant, and the majority of them had a live birth. Congratulations, that's a good news. But what the real question was, not were they able to get pregnant or not, but did they have more relapses or not? Here, you'd have the control arm, a risk of recurrence, any breast cancer event, whether contralateral or metastatic disease, compared to the positive cohort. And they were typically identical, if not numerically better in the positive study. So stopping endocrine therapy for up to 2 years in patients who have completed an average of 2 years is safe as per the 5-year results and as per the positive study inclusion criteria. Please note that patients with very locally advanced disease were not very well represented here. But my patient, she had a T2N0 disease, so she was very well represented in the positive study. So my advice is she can safely go for interruption of the adjuvant endocrine therapy and getting pregnant with a window of 2 years and then getting back to complete her adjuvant endocrine therapy. And this is a 100% safe approach in terms of recurrence. And thank you very much.
Anyone would like to ask Professor Dr. Luai? Okay.
Thank you, Dr. Luai, for your amazing presentation. You suggest a patient with cancer breast want to be pregnant to stop endocrine treatment, and then for 2 years, as you said, and so she can become pregnant and safe. But if the position on the opposite, she is pregnant and she got cancer breast, what's your advice? Early in pregnancy and late in pregnancy?
Well, it depends on the stage and the biological subtype, because pregnancy might interfere with some types of treatment. However, the majority of the treatments that we have for early stage breast cancer can be done during pregnancy. For example, breast surgery can be done during pregnancy. Chemotherapy, anthracycline taxanes can be done during pregnancy. Of course, if you exclude the first trimester, and usually we take some time to complete the diagnosis of the patient. So typically it is easy to complete the pregnancy if it was the patient's wish. Because many patients would have it difficult to take the risk of getting all those treatments during pregnancy. But if the patient want to keep the child, and the majority of the patients actually want to keep the child. So if they want to keep the child, and if we've passed the first trimester, so almost every single treatment apart from the anti-HER2, for example, it's very safe to go during pregnancy. Most of the guidelines recommends treating patients who had breast cancer during pregnancy as per the similar guidelines as those with the non-pregnant.
Thank you.
Okay, any question again? Okay.
My question for Professor Hanan Izzat. Dr. Hanan. Dr. Hanan, thank you for the presentation. My question is about sequencing if the patient is hormone receptor positive and indicated for olaparib. The patient is hormone receptor positive and indicated for adjuvant olaparib. And also indicated for CDK4/6 inhibitor. What is the optimal sequence between the two drugs?
هو الحقيقه احنا عندنا الداتا من الموناركي اي ترايل طبعا الماتيور الموست ماتيور داتا، وعندنا الداتا من الاولمبيا ترايل. لو احنا we're going to choose between both، يعني should we give olaparib or give abemaciclib، الحقيقه احنا عندنا في overall survival benefit مع في الاولمبيا، فاحنا هنبقى more inclined ان احنا ندي البيشنت olaparib as long as ان البيشنت is fitting للكرايتيريا بتاعت الاولمبيا. يعني لو العيانه اب فرونت وعندها اكتر من 4 ليمف نودز، او العيانه بعد النيو ادجوفنت وعندها ريزيدوال ديزيز، او السكور بتاعها اكتر من او ايكوالز 3، فاحنا لو احنا فيتنج الكرايتيريا دي طبعا olaparib will be our first choice based على الاوفرول سرفايفل داتا. لو العيانه if we عيانه is a very high risk and we are thinking of sequencing both olaparib and abemaciclib، so ما عندناش حاجه بنلجا لها غير الكرايتيريا الانكلوجن كرايتيريا بتاعت الترايلز. فاحنا في الموناركي اي كان مسموح ان احنا ندي الابيما لحد 15 months بوست سيرجري. في الاولمبيا كان مسموح ندي up to 2 months only بعد السيرجري. فاذا احنا هنفكر في السيكونسنج يبقى احنا بيزد على الترايل هنضطر نبدا بالاولابريب عشان ال 2 months ويندو بتاع الترايل، وعشان هو عنده سرفايفل اوفرول سرفايفل بنفيت، وبعدين ممكن بعد كده نكمل بالابيما بيزد برضه على ان احنا عندنا ويندو لغايه 15 شهر، وبيزد على ان البنفيت في الموناركي اي كانت بروكريشن فري سرفايفل، يعني انفيزيف وديستنت، لكن مش اوفرول سرفايفل. فديس از يعني in my opinion this is the يعني the most optimum according للترايلز طبعا يعني. الله اعلم.
أماني هلال, have any other opinion?
على sequencing يعني ولا؟ انا موافقه حنان جدا. البراكا ميوتيشن الاولمبيا ترايل كان ليها اوفرول سرفايفل ادفانتج، فاي ثينك اي ويل تراي اي ستارت وذ olaparib، ولو العيانه فيتنج كرايتيريا بتاعت الابيما اي كان ستارت افتر اندينج ذا olaparib. combination of both not known هيحصل ايه سايد افكتس او كده، مفيش عندنا داتا ان احنا نعمل combining of both، فاي ثينك sequencing is the most safe for the high risk patients.
دكتور احمد مجدي has a comment.
I think السؤال ده حضرتك هيبقى بدري قوي، لان I think with the overall survival data اللي ان شاء الله احفادنا هيشوفوها في قدام، لان it needs very long time to follow up. بس I believe لان ال CDK4/6 for now we have an event-free survival with the delta difference of 7.2 7.3 على ال 5 years. لكن overall survival we're still waiting for the data. We don't have data. I believe in the future دي هتبقى الدايلما بتاعتنا. I totally agree with olaparib because we do have an overall survival data, but I'm against definitely of combining them because of the severe toxicity. Okay, the other question would be keeping in mind that we are treating adjuvant patients, or let's put it in another way, cured patients. صح? Would we want to give them all these long treatment cycles? يعني practical wise, I'm not talking data wise. Data wise we don't have still بالنسبة لل CDK4/6s. But would you rather go for a very long treatment for a patient? يعني أنا فعلا بسأل لأن أنا I had one patient literally called me over the phone after 1 week of abema and threw the drug in the basket and said, if this will save my life, I will not continue it. When she was young. Do you think that we should go for all this long period?
I think we have to discuss this issue with the patient herself.
Sure.
Because some patients may choose to to receive the whole treatment, the whole course of treatment, even if the magnitude of benefit is very less. and other patients want to avoid toxicity and may select to choose the hormonal therapy only or the hormonal therapy plus one of them, plus one of the two options only.
Thank you all. Final question for Professor Hanan. Yes. I'm going to put in mind the expenses of the drugs. You know that the olaparib is an expensive drug. I have a very simple question. For whom would you fight sponsoring olaparib as adjuvant treatment? You are convinced with what criteria? You mentioned the Olympia criteria, but for whom you will fight? You are convinced that this is a cost-benefit drug that may improve survival.
طبعا الحقيقه ان احنا يعني every day we are faced with الديليما بتاعه الكوست. بس انا I do have a belief الحقيقه انه if we do have اي درايف عند عيان، يعني if the patient is having a drive a genetic drive، فده بالنسبه لنا بيبقى probably البيشنت دي هتستفيد. لو احنا يعني according to the Olympia طبعا احنا قلنا الكرايتيريا بتاعتها، ولكن انا الحقيقه بالنسبه لي I'm going to fight for triple negative patients اكتر من الهرمون ريسبتور بوزيتيف، لانه البنفيت بتاعهم في الاوفرول سرفايفل اعلى. الحاجه الثانيه البيشنت طبعا اللي عندها ريزيدوال ديزيز بعد النيو ادجفنت شور دي هتبقى هاير ريسك عن العينه اللي باديه اب فرونت which is very rare ما بنشوفهاش. فيعني دول لو احنا بنسلكت بقى مين الاكتر، الريزيدوال ديزيز والعينين تريبل نيجاتيف. انت لو انت عندك واحده تريبل نيجاتيف وواحده هرمون ريسبتور بوزيتيف يبقى ديفينتلي هتفايت الاول للتريبل نيجاتيف. والريزيدوال ديزيز طبعا مش يعني هي تعتبر بور ساين طبعا احنا عندنا كرييت اكس بتقول ان الزيرو ده كمان بتعمل على فكره امبروفمنت للديزيز فري سرفايفل والبروجريشن فري سرفايفل في البيشنتس دول. فايتس ان اوبشن لو احنا ما عندناش الاولاباريبين.
Professor Dr. Luaid, I want to ask you just a small question. When to give induction of ovulation in a breast cancer woman, nulli para, to give or not? She need to get pregnant?
To give, the short answer is yes, she can have induction of
Even
ovulation.
though induction of ovulation, it's one of the predisposing factors to breast cancer?
It was never proven to be a risk factor to have breast cancer. Again, we have limited data regarding this point, but that was never proven. Theoretically الحقيقة I think it will not. علشان induction of ovulation is a very short-term process. What was proven is the long-term hormone exposure. ده اللي عادة كان associated with the risk. بس السؤال اللي احنا متأكدين منه ان اللي عندها breast cancer وهي نالي بارا او حتى لو هي كانت قبل كده عندها بس محتاجه دلوقتي تعمل اندكشن، لانه الحقيقه ليه بيكونوا محتاجين يعملوا اندكشن؟ عشان بعد التريتمنت اوف بريست كانسر الاوفيريان ريزيرف بيقل، فبتحتاج ان هي تعمل اندكشن اوفيريشن حتى لو ما كانش عندها برايمري انفيرتيليتي قبل كده. وات وي ار شور اوف برضه من البوزيتيف داتا الحقيقه اللي اتقدم ان السكند ابستراكت في سان انطونيو اللي فات، انه من السب جروب اللي في البوزيتيف ستادي في نسبه من العيانين احتاجوا يعملوا اندكشن ونسبه حصل لهم عملوا بريجنسي سبونتينيوس. فالسؤال هل الايفنتس البريست كانسر ريلابسز، ودي الحقيقه اللي مور ريليفنت لانه دي اعلى بكتير من حدوث البريست كانسر الى ان ان اكسبوزد. البريست كانسر ايفنتس was the same in those who had ovarian stimulation versus those who had spontaneous pregnancy. دي الايفيدنس اللي عندنا لغايه النهارده. فبالتالي لما المريض بيسالنا غالبا اقدر ولا لا، هو مش بيسال عن الثيوري، مش بيسالنا عن الراي، هو بيسال عن الايفيدنس، لان هو في الثيوري والراي هو فاهم انه في بريجنسي وفاهمه ان في هرمونز وهكذا، لكن هي بتسال هل في ايفيدنس انه ده هيعلي الريسك اوف ريكرنس. لغايه النهارده الايفيدنس المتاح اللي هو افضل حاجه متاحه عندنا دلوقتي العدد العيانين بتوع البوزيتيف ستادي، ما فيش حاجه تقول انه ده هيزود الريسك اوف ريكرنس اوف بريست كانسر.
Thank you so much.
يعني انا الحقيقه يعني انا معاك في الترايل واللي بنقول احنا يعني so much inclined ان it will not affect the patients. بس المشكله في البروسيس بتاعه الاوفرين preservation في مصر. يعني in your practice how long it will يعني it takes. يعني انا جربت الحقيقه ولقيت انها بتاخد a lot of time. فمش عارفه هل فعلا يعني انا مشكلتي هي دي الحقيقه.
يعني الحقيقه دي نقطه في منتهى الاهميه من ناحيه البراكتيكاليتي. لو سالنا نعمل ايه، اول خطوه نعمل اونكو فيرتيليتي كلينيك. ليه؟ لانه في اسئله احنا نتصور ان هي واضحه والجاينيكولوجيست مش يعني ايه البرايورتي بتاعت الجاينيكولوجيست؟ انه يجيب عدد اوفمز كبير. ده البرايورتي. فهو بالتالي هو شيء هو كل حالات الانفيرتيليتي اللي هو بيعمل لها اندكشن ما عندوش اصلا الكويستشن بتاع الوقت، هي معاها 20 سنه تخلف فيهم، فهو فالحاجه فاونكو فيرتيليتي كلينيك دي نقطه مهمه علشان يحدد الاسئله اللي موجوده في الالجوريزم بتاع الازمه. اول حاجه هي محتاجه ولا لا فيرتيليتي بريزرفيشن، سم تايمز هي تقول لا انا مش محتاجه خالص. الحاجه الثانيه هي عندنا في التريتمنت اسبوعين ولا لا، وده اللي يقوله الانكولوجيست. السؤال هي ممكن تكون اقل من اسبوعين لو كان التيم كله بتاع الفيرتيليتي بريزرفيشن عنده الايديا. فهي الحقيقه مش محتاجين، ودي اول نقطه، مش محتاجين ان احنا نستنى داي 2 اوف ذا سايكل، لان احنا دلوقتي لو كنا في داي 5 والعينه جات لنا في الكلينيك معناه ان احنا محتاجين نستنى 4 اسابيع. وده مش حقيقي. في حاجه اسمها راندوم ستيميوليشن بروتوكول بيستخدموه الجاينيكولوجيست طول الوقت، لو حد قال لهم بس ان دي احنا محتاجين اسبوعين بس اخرنا.
Actually, I would like to say something that
So this is the outline of my presentation. I will start with a short introduction, and then I will go through the evidence for CDK4/6 inhibitors in HR-positive, HER2-negative advanced breast cancer, and I will focus a little bit on right choice trial for aggressive premenopausal advanced HR-positive, HER2-negative breast cancer, because fortunately Bahia was sharing in this landmark clinical trial. And finally, conclusions. So what we know about the incidence of breast cancer, if we look at the Globocan data, we have around 2,200,000 new cases of breast cancer annually. And out of these cases, we still have a huge number of deaths, more than 600,000 per year, putting breast cancer as one of the most important health burden worldwide. In Egypt, we have more than 20,000 new cases annually, and out of these cases, we have more than 9,000 deaths every year. Before the year 2024, and in every meeting, we had these curves, almost overlapping of all survival curves, and we didn't have any evidence for superiority of overall survival of whatever available agent for the treatment of metastatic breast cancer. And the choice of chemotherapy was always based on the doctor preference, patient's preference, quality of life, accessibility, and whatsoever, because of lack of overall survival data. Until the year 2014, in HER2-positive disease, advanced disease, when we had the landmark Cleopatra trial, which showed improvement of overall survival, and at that time it was a landmark figure around 56.5, and so we approached the cutoff point of 5 years in a very aggressive advanced disease entity. In HER2-negative HR-positive disease, we didn't have any improvement until the institution of CDK4/6 inhibitors with palbociclib in Palomas and Ripo in Monalisas and abemaciclib in Monarchs trial. And if we look at the inclusion criteria of all these clinical trials, definitely we are not comparing trials by trial, but if we look at the inclusion criteria of each of which, we can easily notice that there is a huge difference in the inclusion criteria. For example, the randomization may be 1:1, 2:1 in some clinical trials. The majority of these clinical trials were postmenopausal, apart from Monalisa 7, which included an exclusive population of premenopausal and perimenopausal patients. Again, the line of treatment may be first line, second line, and the differences in stratification factors according to the endocrine compartment and the metastatic site. Majority of these clinical trials didn't allow for chemotherapy in advanced disease, apart from Monalisa 7, which included some of these, and Paloma 3. Again, if we look at the endocrinal treatment in advanced disease, all of these clinical trials didn't allow for incorporation of endocrinal therapy for advanced disease, apart from Monarch 2 and Paloma 3, which is logic because these are second-line clinical trials. Some of these clinical trials didn't allow for early relapsers, for example, Monarch 3, others allowed for. What I want to say is that the inclusion criteria of all of these clinical trials for the three different agents are different. And if we look back to the pharmacological evidence for differences between these agents are definitely not the same. And as we know, CDK4 dependent lines are more commonly ER-positive breast cancer cell lines, whereas CDK6 dependent lines are mainly hematopoietic, which simply means that if you have a drug like ribociclib and abemaciclib, which are more active against CDK4/6 than CDK4 than CDK6, whereas palbociclib is equally inhibiting both CDK4 and 6. This may partially explain why there is differences in the efficacy between ribo and abema, and this may explain why palbo, for example, failed to show superiority in overall survival, as I will show shortly. Again, if we look at the level of exposure, ribociclib still have the highest level of exposure in plasma as compared to other CDK4/6 inhibitors. And if we look at the off-target selectivity, we have ribo and palbo having fewer interactions with the off-target kinases than abema, and this once again may partially explain why the adverse events of abemaciclib may be more symptomatic than the other two CDK4/6 inhibitors. So if we look at the survival, we all know that forget about palbociclib because it failed to show any superiority of overall survival regarding Paloma 2 and Paloma 3. We have evidence regarding real-life data, but if we look at the randomized clinical trial, we have superiority in overall survival for ribo in different clinical trials and for abema in Monarch 2, as I will show. So if we look at these clinical trials, and once again, I am not comparing a trial versus trial, but if we look at the overall survival, the Mona Lisa 2 showed positivity in overall survival. Again, the Mona Lisa 7 for pre and perimenopausal was positive for overall survival, and the Mona Lisa 3 was positive. So we have positivity in first and second line, whereas for Monarchs, the Monarch 3 was numerically higher but not statistically significant, whereas Monarch 2 was significant. For Palomas, we didn't reach any overall survival statistical significance. So if we look trial by trial, for Mona Lisa 7, which is an exclusive trial for pre and perimenopausal advanced HR-positive HER2-negative disease, if we look at the planned OS analysis, the median was not reached for the ribo-based versus 40 months for placebo hormonal treatment. And if we look at ad hoc analysis, the median overall survival was 58.7 versus 48, which simply means that, as occurred in HER2-positive disease, we are now having nearly 5-year median overall survival, in, which is the highest ever reported with a CDK4/6 inhibitor in a trial which is exclusively focusing on premenopausal aggressive population. Again, if we look at the postmenopausal population in Mona Lisa 7, the median survival for the planned overall survival analysis was not reached versus 40 months, and in the ad hoc OS analysis, it was 53.7 versus 41.5, which means we are having nearly 4.5 years median overall survival, which is once again the longest ever overall survival reported for a CDK4/6 inhibitor in combination with fulvestrant. If we go for the abemaciclib, and if we look at Monarch 3, which included more or less a similar inclusion criteria as I just elaborated, we had abema hormonal treatment versus non-steroidal placebo with PFS as the primary endpoint. And if we look at the interim analysis of Monarch 3, it showed a numerical improvement in overall survival with a median OS of around 67.1 versus 54.5, but it didn't reach the predefined statistical significance level. So if we look at the overall survival curves, for all Mona Lisas, we have positive results. For Monarch 2, we again have positive results, but in all Palomas, we didn't have any overall survival difference. So we can confidently say that ribociclib demonstrated overall survival difference regardless of menopausal status, because we have pre and peri population in Mona Lisa 7. We have post-menopausal populations in Mona Lisa 3 and 2. Again, regardless of the endocrinal compartment, because we have for Mona Lisa 7 tamoxifen or non-steroidal aromatase inhibitors. Tamoxifen was initially an arm in the Mona Lisa 7, and because of prolongation of QT interval, this arm has been omitted, and the only non-steroidal compartment is there in combination with ribociclib. Again, regardless of endocrinal compartment, because even with fulvestrant in Mona Lisa 3 or letrozole in Mona Lisa 2, we still have difference in overall survival. And once again, regardless of the line of therapy, because Mona Lisa trial was first line trial, Mona Lisa 7 was first and second, and the Mona Lisa 2 was first line trial. So if we focus on first line treatment, we still have privilege for ribociclib because it demonstrated significant overall survival benefit across all phase 3 clinical trials, Mona Lisa 7, 2, and 3, and only Monarch 3 was positive and others was not. And if we look at the overall survival difference, it was maintained in first and second line with the use of ribociclib in Mona Lisa 3, because if we look at the longest analysis was around 17 months follow-up from the final protocol analysis, we still have overall survival difference in first and the second line treatments. So we are moving now to right choice trial, and as I said, Bahia shared in this clinical trial, and the population, and this trial was important because, as we know, the standard of care in metastatic breast cancer is to go for first line hormonal treatment, second line hormonal treatment, third line hormonal treatment, except in the presence of visceral crisis. And the question now, if we have an aggressive disease, including visceral crisis, do we have any option other than chemotherapy? And this was the importance of right choice clinical trial. And why premenopausal population? Because we know that the premenopausal population is a very unique population, and it is defined as less than 50 years. We have around 31% worldwide, but higher 42% in the Asia Pacific population, much more higher in the Middle East, around 50%. And as we know, biologically, as compared to others, in this population is a very aggressive disease with poor prognosis. So this is the inclusion criteria for right choice clinical trial, which was based on the fact that before right choice, there was no published clinical study to assess the population of patients with aggressive HR-positive, HER2-negative disease, including patients with visceral crisis in whom chemotherapy was the only line of treatment. Right choice was the first and the only prospective study comparing a CDK4/6 inhibitor plus endocrine therapy combination versus chemotherapy in advanced breast cancer patients. And if we look at the inclusion criteria, definitely HR-positive, HER2-negative advanced breast cancer, pre- and perimenopausal population, and the age is 18 up to 59 years. No prior endocrine therapy or chemotherapy for advanced disease, ECOG performance status of less than or equals 2, and the total bilirubin less than or equals 1.5 times the upper limit of normal, and the vague definition of aggressive disease, symptomatic visceral metastasis, or rapid progression of the disease, or impending visceral compromise, or if we have non-visceral disease, it should be markedly symptomatic, like for example, markedly symptomatic pleural effusion. And the patients were randomized in a 1-to-1 fashion to ribociclib plus non-steroidal aromatase inhibitors and the gozerline being a premenopausal population versus investigator choice of a combination chemotherapy of either docicab, paclitaxel, or capvinorolbine. For Bahia patients, we selected paclitaxel gemcitabine as the combination chemotherapy compartment. And the primary endpoint was progression-free survival. The secondary endpoint was clinical benefit rate, overall response rate, overall survival, and time to treatment failure, time to response, safety and tolerability, again, patient-reported outcomes. And if we look at the definition of visceral crisis, again, we are having the definition of EBT3, which merely defines visceral crisis as the severe organ dysfunction as assessed by signs and the symptoms, lab studies, and the rapid progression of the disease. And the visceral crisis is not the mere presence of visceral metastasis, but implies important visceral compromise leading to a clinical indication of a more rapidly treatment, which was always a very vague definition. ABC5 tried to objectify the definition much more. They are adding example, for example, liver visceral crisis is a rapid increase in total bilirubin to be 1.5 times upper limit of normal in the absence of underlying disease like Gilbert syndrome or biliary tract obstruction. Again, lung visceral crisis is defined as increasing dyspnea at rest, not alleviated by drainage of pleural effusion. It was a trial to do more objectization of the definition of visceral trial. And if we look at the patient's characteristics, it was more or less balanced between the two arms. And we have median age of around 44 years. Slim majority of patients were Asian population. Around 2/3 of the patients had visceral metastasis. And a slim majority of patients, 54%, were in a visceral crisis. The reason for discontinuation of treatment was progressive disease in around 44% in the riboendocrinal treatment arm versus 52% in the chemotherapy arm. And fortunately, the primary endpoint of the trial was met, and we have a statistically significant improvement of progression-free survival. The median PFS for riboendocrinal therapy in a very aggressive population was 24 months versus only 12.6, which means we are doubling the median progression-free survival with a hazard ratio of around 0.54, which corresponds to around 46% decrease in the incidence of progression or death with the use of riboendocrinal as compared to combo chemotherapy. And so we have a delta difference of more than 1 year, very significant. And this data was presented in San Antonio 2022, but the final analysis after final database lock was presented. The final database lock occurred in 10 May 2023, and the final analysis showed a median PFS 21.8 months versus 12.8 months with a hazard ratio of 0.61, still a very significant difference in such an important population. Again, if we look at the time to treatment failure and the 3 months treatment failure rate, the time to treatment failure for riboendocrinal therapy was 18.6. We are more than 1.5 years versus only 8.5 with the use of combination chemotherapy with a very significant hazard ratio, 0.45, around 55% decrease in the incidence of treatment failure. And the 3 months treatment failure rate for the ribo arm was almost half, around 11.6 versus 21.8 for combination chemotherapy. Again, if we look at the disease progression risk in riboendocrinal therapy arm, it was greater for patients less than 40 versus patients more than 40, reflecting a more demanding and a more aggressive population. We can easily notice a wider separation of the curves in patients who are less than 40, and we have a 62% reduction in the risk of disease progression for riboendocrinal therapy or death as compared to chemotherapy if less than 40, and we have around a 29% if we are more than 40. Again, if we look at the time to response, which is very crucial, it was more or less similar between the two arms. It was very important because one may argue that, okay, we are going for combination chemotherapy because it is not about improvement of PFS, it is more improvement of a rapidity of response in order to alleviate the symptoms. However, the time to treatment response was similar between the two arms. Again, if we look at the time to treatment failure, we have in patients less than 40, again, the separation of the curves is much more as compared to patients who are more than 40. And in patients less than 40, we have 70% relative reduction in the risk of treatment failure with riboendocrinal compartment versus combo chemotherapy, and the 3 months time to treatment failure rate was around 16.8 lower for riboendocrinal versus chemotherapy, whereas for patients more than 40%, we have a 42% relative reduction in the risk of treatment failure with riboendocrinal versus combo chemotherapy, and the 3 months time treatment failure rate was around 7% lower with the use of riboendocrinal therapy. In ESMO 2023, there was a very important presentation out of the right choice trial, because we had, as I said, around 54% of the population of right choice trial, including visceral crisis population, patients in a visceral crisis. So one may argue that, yes, the improvement of median progression-free survival in favor of riboendocrinal versus chemotherapy is not attributable to patients who are in visceral crisis, but it is much more attributable to patients who are aggressive disease but not yet in a visceral crisis. So the intelligent comparison of the compartment of patients of visceral crisis versus patients who are not having a visceral crisis was expected to answer this question. And as determined by the investigators, we had around more than 160 patients presenting with visceral crisis, and we have 116 patients presenting without visceral crisis. And in both subgroups, the baseline characteristics was more or less balanced. And if we look at the results, in patients with visceral crisis, the median progression-free survival was similar in both treatment arms, whereas in patients without a visceral crisis, there was around 58% relative reduction in the risk of disease progression or death with the use of endocrinal ribo versus the use of combo chemotherapy. Again, if we look at the time to treatment failure and the treatment failure rate in patients with and without visceral crisis, in patients with visceral crisis, the median time to treatment failure was similar for both arms, with a 22% relative reduction in the risk of treatment failure with riboendocrinal versus combo chemotherapy, and the 3 months treatment failure rate was similar in both groups. Again, if we look at patients without visceral crisis, we have time to treatment failure rate, and the time to treatment failure was longer with riboendocrinal therapy, with a 66% relative reduction in the risk of treatment failure, and the 3 month treatment failure rate was lower with endocrinal therapy and ribo versus combination chemotherapy. Again, in patients with visceral crisis, time to response was similar in both arms, while for patients without visceral crisis, the time to response was longer with riboendocrinal than with combo chemo, again challenging the concept of giving combination chemotherapy to have a more rapid response. Regarding patients with visceral crisis, the overall response rate was numerically higher with riboendocrinal versus combo chemotherapy, and the clinical benefit rate was similar in both treatment arms, whereas in patients without a visceral crisis, the overall response rate was similar in both treatment arms, while the clinical benefit rate was higher with riboendocrinal than chemotherapy. Duration of treatment exposure, once again, in patients with visceral crisis, the median duration was similar in both arms, denoting tolerability of the drug, around 1 year in both arms, whereas in patients without visceral crisis, the median duration of exposure was longer in riboendocrinal arm as compared to combo chemotherapy. And regardless of presence or absence of visceral crisis, these were the adverse events with the historical adverse events of chemotherapy: nausea, vomiting, palmar plantar erythrodiathenia, and so on, were more in chemotherapy as combined to endocrinal treatment. And most of the adverse events of ribo arm were tolerable and benign adverse events, denoting that the tolerability of endocrinal ribo arm was more than the tolerability of chemotherapy arm. So the conclusion for right choice trial is that in this subgroup analysis, of patients with a clinically aggressive HR positive, HER2 negative advanced breast cancer. From the right choice trial, we had a similar BFS with riboendocrinal versus combo chemotherapy in patients with investigator-assessed visceral crisis. And in patients with visceral crisis, we had a similar time to response between the two arms. Whereas in patients with clinically aggressive disease who presented without a visceral crisis, a clinically meaningful median PFS benefit was observed for riboendocrinal as compared to combo chemotherapy, along with a similar overall response rate. And in both subgroups, patients receiving riboendocrinal therapy experienced a lower rate of symptomatic adverse events as compared to chemotherapy. And this exploratory analysis supports that riboendocrinal therapy could be considered as a valid first-line treatment option even in patients who have visceral crisis, which is a practice-changing clinical trial. And this is why this clinical trial was published in GCO. If we look at NCCN guidelines, and as compared to other CDK4/6 inhibitors, ribociclib is the only in both first line and second line to be listed as category 1 recommendation. So in conclusion, we have a very effective drug, which is ribociclib. Pharmacologically, we have evidence to support the use of ribociclib being a more CDK4/6 inhibitor than CDK6 inhibitor, and the duration of exposure will be much more with the use of ribociclib. And evidence-wise, we have very strong evidence in all mature phase 3 clinical trials, including the most recent, which is the right choice trial, which was a practice-changing trial, putting ribociclib endocrinal therapy as a valid treatment option, even in the presence of a visceral crisis. And with this, I thank you for your attention.
Thank you very much, Professor Dr. Ahmed Bastawisi. Any question for Professor Ahmed Bastawisi? Please go ahead.
Thanks, Professor Ahmed. But my question about the maintenance treatment after chemotherapy in visceral crisis, to maintain on hormonal treatment, or we can add CDK4/6 with the hormonal treatment as a maintenance?
If we look at right choice trial, it didn't include patients receiving chemotherapy as induction treatment. It included a treatment naive. It didn't allow chemotherapy for advanced disease.
My question about this patient received chemotherapy, then after the disease control, to maintain on hormonal treatment or to add CDK4/6 with the hormonal treatment?
Yeah, you can add CDK4/6 inhibitor for the maintenance treatment if you started with induction chemotherapy, although the evidence is much more if you are starting the combo endocrinal and CDK4/6 without chemotherapy.
Okay, any other question? And so, thank you very much, Professor Dr. Ahmed Bastawisi, for the excellent